Hi, now we're going to discuss a specific cardiac defect. This cardiac defect is called Tetralogy of Fallot. Here are your learning objectives. They are in line with the learning objectives of a cardiac exam, clinical manifestations, knowing what the nursing management of pediatric cardiac anomalies include, differentiate between cardiac and acquired cardiac conditions, congenital and acquired cardiac conditions, understand the difference between the etiology of pediatric patients with congenital and acquired cardiac conditions, explain the nursing considerations and collaborative management of pediatric patients with congenital and acquired defects. So in a different slide deck, we are going to actually discuss the acquired cardiac conditions, but this one we're going to focus on Tetralogy of Fallot. So Tetralogy of Fallot, it's called Tetralogy 4. So there are 4 major defects that we are looking at. The first one is pulmonary stenosis, where as you can see here, they're labeled 1, 2, 3, 4. Pulmonary stenosis is the first defect. The second one is a right ventricular hypertrophy. So as you can see here that the right ventricle muscle is a little bit enlarged. And then you have an overriding aortic arch. So as you see in the third defect, you have an arch that overrides both the right and left ventricle. And you also have a VSD, or ventricle septal defect, as you see in this number 4. So as you can see in this this diagram here, you have red blood, blue blood, and purple blood. This purple blood is the mixed venous and oxygenated blood, so it's got a lower saturation than just the oxygenated blood. So you have blue blood and red blood mixing together and going out into the systemic system. Here is just a picture of a normal heart versus the Tetralogy of Fallot heart. As you can see again, the defects, anatomical defects that you have here. You've got the right hypertrophy, the VSD, the overriding arch down here, and then you have the pulmonic stenosis right here. So the pulmonic stenosis is the pulmonary valve that leads to the lungs. So there's stenosis that obstructs the right ventricle leading into the pulmonary arteries. So talk about pulmonic stenosis, pulmonary valve defect or narrowing of the pulmonic artery. So this brings blood away from the heart and goes to the lungs. And this actually is the result, and this is why you have the right ventricular hypertrophy. So the right ventricle has to work harder to overcome that obstruction, the pulmonic obstruction going to the lungs. So you get the right ventricular hypertrophy because of this stenosis as a result. Again, the right ventricular hypertrophy is just the enlargement of the ventricle muscle. And then you have the overriding aortic arch. So this arch actually overrides both the right and left ventricle, and that means that you have that mixed blood going out into the body. As you can see, this is the normal heart here, where you have the pulmonic arteries and the aorta that are completely separated. But you have a lot of mixing going on in this blood and the ventricles. And then you have your VSD. Now the VSD, again, here's your normal heart that has the normal ventral septum there. And then you have the septal defect here. And so this is what mixes the blood. You have the red blood going into the blue blood, and because you have the aortic arch that actually goes into both, or takes blood from both ventricles, you have the lower oxygenated blood going out into the body system. Clinical presentation, generally you can see it depending on the severity of the defect. You can see it from birth. Also depends on the degree of the pulmonic stenosis. So the severity and the treatment will depend on how severe this defect is. So if it's a very severe pulmonic stenosis, you're going to see the symptoms immediately after birth. They will be smaller babies. They're not getting enough nutrients. Their heart working harder, and the metabolic rate is actually higher because his heart is working harder. They're also going to be see tachypnea because they have shortness of breath. So they're going to be breathing faster and harder because of this. So sometimes these patients will have what they call a TET spell, sorry. Um, so when you see a TET spell, they will have decreased oxygenation. That's because when they are crying, the pressures change and you get more of the deoxygenated blood going out to the systemic systems. You'll see a cyanosis when they're crying or they're eating. They'll get more tachycardic. They will also get very diaphoretic and their temperatures will increase. So basically, when you have TET spells, the complications can include heart failure, failure to thrive because they are using so much energy to make their heart work that all the calories are going towards making sure that their heart is functioning. You can get arrhythmias. They are more prone to infection. Blood flowing to the lungs can increase the pulmonary hypertension. So you can get pulmonary hypertension. You can get a decreased cardiac output and then hypoxia. So you'll see a even lower saturation. These patients in general, they have low saturations at baseline, but when they have a TET spell, their saturations can go very low and they will turn like a bluish hue because of the cyanosis and the deoxygenated blood that is getting pumped out to their systemic system. So let's go, actually, if we go back to the TET spell, or just to talk more about a TET spell, there are certain things that you can do when they are having a TET spell, and those include putting their knees to the chest, which will help the blood flow back to their heart. We want to keep them calm, so we basically do whatever we can to calm them down and keep them comfortable. A lot of times we will use medications to also help them feel comfortable. Morphine will help them, will open up their pulmonary veins, and the blood flow will improve in their lungs. That's why we use morphine as opposed to any other drug if we feel like they're in pain or that they're very irritable. So they also are prone to be diagnosed with failure to thrive. Their increased calorie needs are related to their increased metabolic demands. However, they do tire easily when they're eating, so it's kind of a double-edged sword. So they have increased metabolic demands, so they need more calories, but they get tired when they're eating, so they don't take in as many calories. So there you get a deficit in calories and you get a smaller growth, or they're not growing as fast as other babies their age. So what we do for our interventions on these patients, we will give them high calorie formulas or give them supplements. We will give them frequent feedings so that they don't tire so easily. So smaller and more frequent feedings will help with being able to ingest enough calories so that we don't tire them out in that one big feeding. And sometimes if they're not able to feed or not able to get enough bottle feeding or feeding by mouth, we will supplement with tube feedings. So we'll have a minimum calorie requirement for these patients, or a minimum intake, and everything else that they don't take in themselves, we will give it to them in supplements of tube feedings. So symptoms can include, if they're having TET spell, difficult rapid breathing, or just being a Tetralogy of Fallot baby. These symptoms include the difficult rapid breathing, they fatigue easily, they'll be very, very fussy, they're just not feeling good because of the low oxygenation that they have in their system. You will definitely hear a heart murmur on these babies. So when you're listening to their heart, you will hear that murmur. And they will have desaturations. So they will saturate at baseline lower than normal, and when they're having their TET spells, they'll even go lower than that. So our nursing considerations for these patients is we're going to cluster their care. That is the main consideration. We're also going to make sure that they get their medications on time, that we measure their I's and O's very closely, that we monitor their heart very closely, so they're going to be on an EKG monitor. So we're going to monitor their heart rate and monitor for arrhythmias. We're going to weigh them every day at the same time to see if they're gaining weight or losing weight. We want them to gain weight, but if they're getting too much weight, that means that they are retaining fluid and that they're getting fluid overloaded. So we need to make sure that we manage that as well. We're going to also monitor their saturations, monitor their breathing. If they need supplemental oxygen, we can give them a little bit of supplemental oxygen as needed. So these are all things that we can do for these babies, but keeping them calm and comfortable is the main priority until they can get their surgical fix. Because the only thing for these patients is a surgical intervention. So when you do present with the TEP baby and you are getting their health history, we want to know about their prenatal care, what kind of delivery that they had, the maternal risk factors that can contribute to this cardiac defect, and those risk factors include smoking, any medications. Some medications will put them at risk for developing Tetralogy of Fallot. The age of the mom also, older moms have a higher risk of cardiac defect, and other medical conditions as well, including diabetes and rubella infections. So these are all things that we want to know prior in their health history so that we can understand what their risk factors were. So diagnosis, we diagnose this with the echocardiogram. Again, this is the ultrasound that looks at the structure, or I'm sorry, this is the test that measures their electrical output. So we do an echocardiogram to see if they have any arrhythmias. We do an echocardiogram to look at their structure of their heart through ultrasound, and then cardiac cath is another way. We need to see what the pressures are, see if they have any pulmonary hypertension. So we need to know all this information before they get a surgical repair. Collaborative care, so they're not just going to be followed by the physician and the nurse. It's going to be a team approach. The collaborative care would include the nutritionist, would also include maybe a physical therapist or an occupational therapist, and a lot of parental education by everyone on the team. So for the fix, or surgical intervention is the only way to fix this. So what they're going to do in the surgical intervention, it can be what they call staged repair, meaning that they might do one surgery and then wait a while, let the patient recover, and then do the next surgery. This all depends, of course, on the severity of the defect and whether or not they can wait to do all of it, or if they can do this in staged, or they do need to do it all at once. So what they're going to do is they're going to widen the pulmonary valve. They're going to repair the VSD with a patch. And they're going to shave down the right ventricle, so take away some of that hypertrophic muscle on that right ventricle.